We were fortunate enough to grab Jerome Adams, who's an anesthesiologist, as you can see by the funny headgear there, and the 20th Surgeon General of the United States in the past administration. And Jerome has been a great friend and thinker, and somebody who, as you could gain from my moderation, I really admire, because he's a very straight shooter in terms of telling us what we need to hear. And so, Jerome, we've been talking about the usual stuff with the usual suspects in terms of improving population health and thinking about life expectancy and well-being and investments in health. And one of the questions I'd have for you is, reflecting back on some of those reports that you actually released just as you were leaving the administration last time, you talked about and engaged different stakeholders. They're not the stakeholders in this room. And so what I've really appreciated is your ability to talk a bit about some of those strange bedfellows and really critical partnerships, whether that's, we heard a great presentation from Washington State. It's like, where's Amazon and Facebook and Google in this? Where's the chamber? So love to get a couple minutes of your reflections, and then I'll let James decide whether we're allowed to ask questions or not. But thank you, my friend, for being here.
Fantastic. Well, thank you so much for being here. And I actually was eavesdropping earlier, so I had my one AirPod in, and was listening into some of the conversations earlier on. And just want to say thank you all for coming together. Thank you for continuing to be passionate about this issue. And I'll give you a few reflections based on what I heard earlier. Some are going to be validations of what you're already doing. Some are going to be challenges to think outside of the way you're already doing things. And I want to start off by just invoking the venerable Dr. Martin Luther King Jr., who famously said, of all injustices, inequality in healthcare is the most shocking and the most inhumane. And he said that over 40 years ago, but he literally could have said it today. He could have said it at the beginning of this event, and it would have been just as true, just as relevant. Now, starting with that, I think it's important for us to break down what he didn't say that I think it's important that we consider. And number one, he talked about inequality, but inequality isn't equity. And you all know this. I don't need to take my time explaining to you the difference between equality and equity. But unfortunately, most of the public has no clue what equity is or why it's important. So we need to do a better job of explaining what equity is and the difference between equality and equity, because even some of our potential partners out there will still fall back on the equality argument and feel like they're doing enough without understanding why equity is so important, giving people what they need versus giving everyone the same thing. And when we're talking about equity, I think it's really important that we work hard to widen the tent beyond race when we're having these discussions in people's minds. And I will tell you, I'm in a very conservative state. I've worked in conservative administrations. And when people hear equity, they immediately go to race. And it's not that we should shy away from honest discussions about race, but you run into a lot of bias, a lot of stigma against the ideas of talking about bias and stigma. But you also run into the WIFM problem, the what's in it for me problem. And so when I talk about, and I'm the director of health equity at Purdue University right now. And yes, I talk very openly about race, but I also lead with explaining to people that equity versus equality is about making the decision whether or not you give everybody a ramp to get into the building, or whether you give the people who are differently abled a ramp to get into the building. Equality is giving everyone all or none, but that's not meeting the need. And everyone can relate to someone who is differently abled and understand why a person who's differently abled might need a different amount of assistance. I'll also often, particularly in conservative states, but this flies everywhere, talk about veterans, because we know that they face disparities. I think it's important that we continue to lift up and talk about rural communities. Again, here in Indiana, There's not anyone in the legislature who can't relate to the challenges of being in a rural community. And when you start there and you help people understand that they're under the tent and not being asked to build the tent for someone else, then I think that opens up the conversation a whole lot more. So I think it's important that we acknowledge that equality isn't equity, and that equity isn't something that most people are familiar with or that they're comfortable with as it's currently being defined. Challenge, and I'm going to be honest about challenges. We are facing a battle against the concept of wokeness. And without getting too political here, there's someone who very well could be president in the not too distant future, who is on the record as defining wokeness as the belief that there are systemic injustices in American society and the need to address them. And that is a quote. And so, again, I think it is incredibly important that we help people understand the importance of addressing equity and inequities and how it impacts everybody. And we've got to understand that we're facing some pretty significant headwinds, and we're going to continue to in the future if we can't get more people to understand the importance of equity. I'm wearing my hospital jacket right now. I also often talk about equity through the lens of quality. So in a healthcare setting, no one argues that if you find differences in outcomes on a quality metric that we should address it. Well, that's what disparities are, no matter which way you slice them. And so I think it's important that, again, we show people and talk about this in a way that is not just doing the right thing, the heart, but we need to appeal to the head and to the wallet and say, this is a quality issue. This is an issue that impacts everybody if we're going to be successful. So that's number one. Equality is an equity, define equity. Number two, and again, this is validation for you all, but it's our 80-20 problem. Healthcare is not health. So Martin Luther King talked about healthcare, but we know healthcare isn't health, and that actually healthcare, by many estimates, is only about 20% of what contributes to our overall health. Yet we spend 90% of our time, our talent, and our treasure talking about, fighting about, arguing about, and ultimately funding 20% of the problem. So we're not going to get to where we need to be unless we change that dynamic. A couple things that are going to be needed. Number one, we need payment reform. Some of you have heard me say this. We don't have a healthcare system. What we have is a sick reimbursement system. We aren't focusing on health, and we certainly aren't doing it from a care perspective. We're focusing on disease and sickness, and we actually don't do the things that the evidence base says we should do. We do the things we get paid to do. So we have to embrace payment reform. We have to embrace value-based purchasing, and both the Trump administration and the Biden administration and the Obama administration all recognize this. So I think we really need to lean into trying to help the healthcare industry shift to value-based care. We need to get to the payer. What does that mean to me? Well, I'll give you a real concrete example. One of my favorite examples of the power of a single payer system is the VA's decision to tackle and eliminate hepatitis C. This is something that there's few, if any, other healthcare systems that have taken this on. And the VA said, we're going to do it. And they got everybody tested and they got everybody treated. And they've about eliminated hepatitis C in the VA system. Why did they do it? Because they're a single payer system and their incentives were aligned. Now, before anyone goes too crazy one way or the other, I'm not arguing for a single payer system overall. Even Bernie Sanders was on the record just a few weeks ago, I think it was last week, acknowledging that we're not going to get there in the United States, and certainly not anytime soon on a national and coordinated level. But what we need to do is find and create those micro single payer systems like the VA, like large employers, and really get them to understand that if they keep spending their money on 20% of the problem, they are going to continue to go backwards. And right now, a significant proportion of that healthcare expenditure in the United States is being borne by businesses. We also need to embrace lifestyle medicine. And so I talked about a sick reimbursement system where we treat diseases. we really need to embrace the idea of treating behaviors. And I appreciated the comments that were made in the last session about the difference between the US and life expectancy in other countries really comes down to our behaviors. Well, we're not treating the behaviors. We're treating the sequelae of the behaviors. We're treating the diseases. We're treating the trauma, but we're not treating the actual behaviors. And so lifestyle medicine, figuring out how we incorporate it into our practices, figuring out how we pay for it is going to be critical if we're going to turn things around. And then someone mentioned digital health. I'm a big proponent of the power of digital health to advance health equity because I think it can increase access, it can democratize health care, and it can help us get to this place we want to be of health care without walls. So right now, health care is you wait till you get sick, you call your doctor, you make an appointment, you drive however far, a couple of minutes to a couple of hours, and most, more like a couple of hours for far too many people across the country. And you go in for you go in for a visit that starts late and that it's far too short to tackle your issues. And we think that's going to turn things around. Digital health allows you to pull out your phone and get an answer to your question right away in your home. It allows your provider to be able to understand what's going on with you. It allows you both to be able to better understand with COVID, for instance, dashboards. It allows us to be able to understand what's going on a population level in our communities, in addition to what's going on with our patients. And so I think we really need to embrace digital health if we want to shift from traditional healthcare to overall health. And then the final point I'll make is that in a capitalist society, businesses are cheap. And far too often, businesses are not at the table. So as Atul mentioned, as Surgeon General, I put out a first of its kind report called Community Health and Economic Prosperity. And why was it a first of its kind report? Because the audience wasn't the choir. It wasn't people who were already invested in health and healthcare. The audience was the business community. And we worked with the Chamber of Commerce, with the UVA Darden School of Business. We wrote it, we rewrote it several times to make sure we were speaking in their language versus in the traditional health language. And we found exemplars. And we asked them why they were leaning into health. And yes, many of them were doing it because they felt it was the right thing to do. But they also were doing it because there were business dividends to doing so in terms of building their brand, in terms of protecting and promoting the health of their workforce, in terms of lowering the second highest cost. Number one cost for most companies is labor. Second highest cost for most companies is healthcare. And so we need to really have business at the table because number one, they're that micro payer that I'm talking about. They're taking on 40 to 60% of the cost, depending on your market, of our out of control healthcare system. So they have a vested interest. But also, I'd much rather have the number one employer in your state going to your state legislature arguing for a health policy than having your health commissioner. And I was health commissioner of Indiana. I was the former Surgeon General of Indiana. When I make a statement, it gets news in Indiana. But you know what gets more news? When Dave Ricks, the CEO of Eli Lilly, makes a statement in Indiana. And it's not because he's in charge of a health care company. It's because Eli Lilly is the largest employer, one of the largest employers in our state. And so we need those people, those Dave Ricks of the world, to help us carry our water when it comes to the policy changes that will take place, that need to take place in order for us to shift from a sick reimbursement system to a true health care mindset. And I think if we can do that, you'll see much more success. I love stories. You all know this. I'll finish with a story. If you ask a kindergartner whether smoking is bad for you, they'll be able to tell you smoking is bad for you. It's not a lack of education that we still have people smoking. And it's well known that the higher the cost of cigarettes, the fewer people smoke. Well, in Indiana, we still have one of the lowest tobacco taxes in the country. Hasn't been raised in over 20 years. The problem is that we go to the legislature and we try to educate people. And they know smoking is unhealthy. And they'll have 3-4 hours of testimony from public health experts talking about how bad smoking is for the state. And then they'll have, and this happens every single budget session, every single year, they'll have maybe a half an hour, 45 minutes of testimony from the gas stations, the mom and pop bars, the casinos, that say, yeah, smoking's bad for you, but if people can't get their cigarettes here, they're just going to go across the border and get their cigarettes. And you're just going to be driving tax money away from our state to another state. We should educate people. We should let them make up their own minds, but we shouldn't drive away revenue from the state. And who wins the argument every time? For 20 years, the business case. So it's not to parade more health people with the same old health arguments if we want to get our tobacco taxes raised. It's to get the Dave Ricks. It's to get Cummins, another one of our big employers. It's to get Roche, another one of our big employers. It's to get many of these other large anchor employers and communities across Indiana saying, look, if we can't become healthier and lower our expenses and be able to rely on our workforce, we're going to move our jobs to another state or another country. And when that happens, all of a sudden the legislators' ears perk up and they go, oh, well, I guess we better raise our tobacco taxes. And so I tell you that because, again, we need to really make sure business is at the table and that we understand their priorities so that we can speak in their language. And ultimately that we're having them help carry our water for us. So I don't know if I went too long or too short a tool, but again, wanted to take those 3 big points. And again, thank you for having me. And I'm happy to I'm going to hang on anyway because I want to listen. I'm happy to answer questions if people have questions, but I'm also happy just to get back and listen to the conversation because it's been amazing so far.
Well, thank you so much, Dr. Adams. I think what we're going to do is have the folks here in the room and online thank you and express our appreciation for joining us. If you'd like to hang on, go ahead and do so. And if there's somebody in a room that needs your attention, we get it. So we know that you have a job to do. So thanks so much for joining us. We really appreciate it.